welcome everyone to Global Health Talks. Global Health Talks, as you know, is a global conversation with experts in various fields of health and medicine who are monitoring and ultimately improving the way the world has conversations about a variety of different types of issues and problems. Today, I'm really delighted to have not only an avowed expert, professor of surgery at Medical College of Wisconsin, an adjunct professor at Vanderbilt University, but beyond all that, he's someone who's authored over 200 manuscripts and reviews and articles on infection control. And perhaps most importantly, he has for over 15 years been a consultant to the Food and Drug Administration, specifically on infection control and implantable devices. And at this point, I will depart from Dr. Edmiston and I will call him Chuck because he's also a dear friend. Chuck, we're going to kind of zero in because you have a vast experience, and obviously as epidemiologist and professor of surgery, you have many, many tangents and many areas you can discuss. But in the time that we have, we want to talk about surgical infection. How prevalent is it? What percentage of surgeries are greeted by post-operative infection, not only in the United States, but if the information is available globally, and what accounts for spikes in that in different countries. And then I want to step down on that a little bit and kind of dig in from you and determine what you feel are the causes and how we might be able to invoke programs and protocols to improve. So without eating up any more of this valuable 5 minutes, how prevalent is surgical infection, Chuck?
Well, Michael, that was actually a difficult question to resolve until about 2 years ago when the journal Lancet Infectious Disease published an article in which investigators had gone out to about 343 healthcare institutions around the world, in fact, 66 countries, South America, North America, Europe, the Asia Pacific countries, to determine what kind of infections occur and what the percentage was. So globally, they looked at abdominal procedures because they're very common. Globally, the infection rate for abdominal procedures was about 12.3%.
Wow.
But then they actually segmented that out based upon high-income countries, low-income countries. And in the high-income countries, the infection rate was about 9.4% for abdominal procedures, as opposed to the the low-income countries, the infection rate was about 23%. Now, I should point out that, we tend to look at the developing world as having a lot of healthcare issues, a lot of crises, but we just published a paper in Diseases of Colon and Rectum in December, in which looked at 107,000 colorectal patients using this large database that comprises about 65% of the American public. And what we determined by this longitudinal study is that the colorectal infection rate was about 24%. And that's in a developed country in the US.
Wow.
So obviously we can look at countries in Asia or countries in Africa and say, well, they have a very high infection rate. But at the same time, we can look at our own society and in selective scenarios, find rather high infection rates.
Wow, that is remarkable. It had been my understanding from the reading that I had done, and this is not as current as yours, was that this rate was somewhere between 1% and 3%. that it was not caused by surgical error. And so it just comes with the territory. But what you're telling us is alarming, even at 9–10% for the states, and globally in depressed countries up to 24%. If it's not surgical error that is in large measure responsible for this, what is it, and how can we dampen this problem?
So, Michael, I've been doing this since 1977, starting when I was training at Vanderbilt University. And I can tell you, it's always been very easy to blame these infections on surgeons and surgical technique. But actually, that's responsible for a minority of the infections, maybe 10%, a little bit more. The vast majority of the infections are really associated in 2021 with comorbid risk. Patients are presenting with obesity, diabetes, COPD, other types of risk factors, alcohol consumption. All of these play an adverse role. And there was a wonderful paper published in 2017 by the Mass General Group up in Boston, where they did something that was very unique. They looked at layering on one risk factor after another when they investigated their colorectal patient population. So they determined that if you and I were going to have a colorectal procedure and we had only one risk factor or no risk factors, our risk for infection was about 2.3%, which is almost identical to what the risk factor is for a total joint procedure. However, if you and I had 4 or more risk factors, then the colorectal infection rate escalates above 13%. So these comorbid risk factors play a significant role in terms of the morbidity of our patient population. And there's another factor that comes into play too, and it's institutional support. Because if we're going to mitigate these risk factors, we really need the support of our institutions in terms of providing the resources that we need. And it's been my experience, especially in the United States, where I've done a lot of work in this area, is that when they say it's never about the money, Mike, it's always about the money.
About the money. Right.
So if we need special resources, there are all these budgetary concerns that's quite often impact upon our ability to get these resources. And it's even worse in developing countries where they have minimal budgets for healthcare. So it's a tremendous problem. There are a myriad of factors, but there are some solutions in terms of how we can deal with these.
What are some of the societal protocols that you would like to see implemented to at least make some sort of check in this? Because it sounds like you understand absolutely why it's happening. So there's even more excuse not to allow it.
So let me tell you what my feelings are. First of all, from an institutional perspective, there are 4 barriers to improvement. The first barrier is complacency. Well, this is the way we've always done it. There's no reason to change. That's laxity. That's out of the question. The other issue is the lack of specific goals among the various healthcare professionals. Nursing has their own priorities and goals. Surgeons have their priorities and goals. Institutions have their priorities and goals. And sometimes these priorities and goals just do not mesh. That's also a significant problem. Poor communication is also an issue. We hear about that quite a bit when we're trying to describe how we want to move forward in terms of putting these these innovative technologies forward. We just have to have everybody on the same page. But the other issue, and I sort of hinted on that a few moments earlier, is the lack sometimes of institutional support. So that's how I look at it from an institutional perspective. But from in the down level, very low level, what can we do? Well, about 20 years ago, we saw the development of what are called surgical care bundles. The surgical care bundle is a series of innovative strategies that are evidence-based that have been shown to mitigate comorbid risk factors for patients. For instance, I've had surgery 3 times. Each time I had surgery, I was requested to take 2 antiseptic showers the night before and the morning of. So I took 2 showers in total. The purpose of that was to reduce the bacterial population on my skin prior to going to the hospital. And then when I went to the hospital, I would actually have another cleansing just prior to the incision. So that's very, very important. And we spent about 15 years studying that in the Department of Surgery at the Medical College of Wisconsin to validate its efficacy. The other issue is to address hyperglycemia. Patients who are diabetics try and bring their blood glucose down to a reasonable range so they're not at risk for infection. Smoking cessation. You'd be surprised how many surgeons today are reluctant to operate on smokers. Why? Because patients who smoke have what is called poor angiogenesis. That's a big word. What does that mean? These patients have an inability to produce new vascular conduits like capillaries. So it has an impact on post-op wound healing. The misuse of antibiotics. One of the things they discovered in the Lancet Infectious Disease Journal was in many of the developing countries, there's an overuse of antibiotics, which contributes to antimicrobial resistance, which impacts on surgical site infections. Patients who have obesity, and the reason they have obesity is because of their dietary habits. But those dietary habits really prevent them from getting the important micronutrients that they need, including zinc and some of these other nutrients. And these are very important in terms of the ability to metabolize glucose. That contributes to the diabetes issue. So there are all these comorbid risk factors that we clearly have identified in 2021. And it's important to put in place these mitigation strategies to reduce the risk within this patient population. Sometimes people have said to me, Mike, well, this is kind of a complex issue. Can you get it a little more simpler? Well, from an engineering perspective, think about in 1969, we went to the moon. How did we get to the moon? We built an engineering system that was so robust that when certain key systems broke down on the flight to the moon, and systems did break down, there were backup systems that came forward to take up the slack. That's how these surgical care bundles work. They work in a cooperative fashion. So if one system is failing, another system can come forward to mitigate that risk. And it's well accepted as a strategy around the globe. And we now have seen a myriad of papers in a variety of surgical disciplines showing the benefit of these surgical wound care bundles.
Wow. You know, nobody asked for COVID, obviously, but I think the average population now understands enough about comorbidity relative to age, smoking, asthma, allergy, diabetes, anemia, that when you carry these things in with you into a surgical suite, it's similarly when you go in for your surgery, these are all situations that exacerbate your problem, which at least allows the surgeon and the surgical team to take a look at every case by case, and realize what the bad percentage or what the good percentage will be on proceeding further. Now, you've talked about the internalized conversation within the surgical team, within the hospital, and throughout the medical system. Is there a conversation with the patient? And does the patient play any role other than dictating, obviously, the very simplistic comorbidities that they may have? Is there any place for the patient in this conversation as well?
Absolutely, Michael. When I had my first surgery about 25 years ago in essence, and Arrow was a faculty member in the Department of Surgery, essentially they said to me, well, this is when we want you to show up. All right, that was pretty much it. In my last surgery, which was just a year ago, I was fully prepared before I went into the OR as in terms of what they expected of me, what I needed to do prior to surgery, and also what I need to do post-operatively to ensure I have an optimal outcome. That's very, very important. And I think I've mentioned this once before. We've reached a point now where we want the patient to be part of the solution and not part of the problem. So obviously, the patient plays a critical role. Also, the patient's family plays a critical role in terms of optimizing their outcome.
You know, this brings up something, and it's sort of an aside, but in doing some recent work on autologous mesenchymal stem cells, and almost the reluctance among patients to do something that hadn't been FDA approved necessarily. There was a cash procedure that insurance would not cover. And they want to know, is there anything that could go wrong? And what was reassuring was, yeah, the thing that can't go wrong is it's cash pay, but you can't get hurt. We're giving you your own stem cells. So you're not going to reject them, but possibly you're just not going to get the desired result. And to which then the patients would always say, do you mean there's no other risk than that? I go, yeah, there's another risk of your orthopedic surgeon using a dirty needle. And I'm not inclined to think that's going to happen. So the reason I bring that up is because patient conversations are non-technical, but they are hugely important. And so I do know that infections in hospitals, particularly among the elderly, particularly pneumonia, particularly other kinds of infections, are the things that even if your surgery is 100% successful, you might suffer the consequences after you get out. So it's high time that we describe these protocols. Thank you for the wonderful work that you're doing and giving us our global look at what's happening. Now, in some of these very, very difficult countries, what are the key factors that you feel in let's say a third world country, which is experiencing a quarter of their surgical outcomes with infection? What's that attributable to?
It's attributed to a number of factors. Comorbid risk is also important in these third world countries. But of course, the availability of resources within that healthcare system is very important too. A good example, when a patient has a surgical procedure in a third world country, there's probably minimal or little follow-up per se, especially if the individual lives out in the countryside. He's not near the hospital, so he can't come back. In this country, we now have the systems in place that if I develop what I think is a post-operative wound or my wound gets very red, I can actually take a picture of my wound and send it to the clinic. They'll evaluate it and say, okay, you need to come in. That's not available in most of these countries. The other thing that I mentioned very early, which I think is very problematic, is that one of the keys to reducing risk is to give patients prior to surgery, about 30 minutes before surgery, antibiotic prophylaxis. The purpose of that is to have appropriate concentrations of antibiotic in the wound to mitigate any contamination that might occur during the surgical procedure. That's a standard of practice that's existed for almost forever.
Is that broad spectrum? So
what it usually is, depending on the surgical procedure, if it's an orthopedic procedure, it tends to be very narrow spectrum because we know there are certain organisms that cause infections in orthopedics. If it's a colorectal procedure, of course, Michael, is going to be broad spectrum because you have a myriad of bugs residing within the gut. The problem is not so much how they focus their delivery, it's what they do after the surgery. And what we've discovered in some of these countries, because they want to hedge their bets. So they figure we're going to give these patients antibiotics a week or two post-op. What that inevitably does is that encourages the development of resistant pathogens, which becomes more problematic for the patient. One of the other issues that's very important in many of these third world countries is access to clean water, access to be able to shower in a safe and clean environment. That may not be available to those patients. So there's a lot of hurdles that have to be overcome, especially in some of these third world countries. Having said that, I've spoken to a number of my colleagues who've gone abroad as missionary physicians to work in these countries. And they've always come back and says, Chuck, you know, we do the best job we can. We talk to our patients. We tell them what we expect from them. And the vast majority of them do very, very well. It's the ones who have significant comorbid risk. Those are the ones that are most vulnerable, Michael, within that environment.
Is that a psychological factor that brings them on?
It can be a social factor too. There's, you know, you have to look at the local customs within the environment. It's probably, as a physician going to a foreign country and imparting your knowledge upon them, they may have a very rudimentary knowledge of what's expected of them. But when you talk to them and say, this is exactly what I want you to do, well, that may be far and above what they've expected to do in the past. So I can tell you in the US, and I think you've experienced this too, is that there's full transparency. You know, you go through informed consent. They tell you about all the risk factors, what could happen, that's good, what could happen, that's bad. And then they also talk to you about discharge planning, what you need to do post-op. Does that occur in all of these third world countries? Not always. In a lot of the countries, I can tell you it occurs in Indonesia, it occurs in Malaysia, it occurs in Vietnam and Thailand. These physicians do a very, very good job in terms of informing their patients, making it as transparent as possible. But again, in the remote communities where these patients come in from these remote communities, then they go back to their homes. They may not have that kind of immediate access when they encounter some sort of post-operative complication like an infection. So that's a challenge in these environments.
I have a very dear friend, a Stanford surgeon, who has, and I'll keep him anonymous, but he's launched a company where he's featuring something called Clinic in the Cloud. And he is actively, this is just a passion with him, just like I know you have passion. The greatest doctors in the world are people who, for whatever reason, have passion. And we were chatting the other day, and he said, you know, you have to do more than make the connection in rural areas or in other countries that are underserviced. You can make the connection, you can have the synapse for best medical care, but you have to have some way to deliver it. There has to be a conduit for delivery. And I think with infection, it's, you know, people, I've noticed this, you know, when you take cephalexin or amoxicillin or something and you're told you got 8 tabs, take them all, don't quit when you feel better, but I'm not giving you any more. And that pretty much outlines what our relationship is going to be with our antibiotics. But in other countries, antibiotics are pretty freely available, and they're almost cliche relative to aspirin. I mean, in some of the countries you mentioned, it's paracetamol, but there are people walking around with antibiotic pills, and whenever they feel some sort of problem, they're popping antibiotics. And when I hear about this, I go, no, that's not a path you want to go down, particularly since the more we use our antibiotics, the more we have to start coming up with new ones. Are we safe now in our available regimen of antibiotic treatments, or have we used them now so much, particularly with COVID, that we better start finding some new ones?
Well, you know, Michael, that the heyday for antibiotic discovery was the 70s, 80s, and early 90s. We haven't done very much in terms of discovering new antibiotics. The key word now, and I'm sure you're aware of this, is antibiotic stewardship. I mentioned this Lancet infectious disease article. Well, that came out in May of 2019. In June of 2019, I was invited to Singapore along with about 50 or 60 stakeholders from the Asia Pacific region. The purpose of this presentation, this meeting, which was funded by Ethicon, the purpose of it was to bring stakeholders together and talk about how we can develop protocols and strategies that are appropriate for the Asia Pacific region. It was also discussed, how can we develop surveillance programs to detect these infections? And finally, a discussion ensued, how do we promote antibiotic stewardship within the Asia Pacific countries when, as you mentioned, these antibiotics are given out like candy? So that study, that 3 days we spent in Singapore actually resulted in 2 publications that were published this year, one in Antimicrobial Resistance and Infection Control, and the other in an Australian journal, Infection, Disease and Health, where we talked about some of these issues. The purpose of those publications, along with these stakeholders from Thailand, from Vietnam, from Australia, Malaysia, Indonesia, China, Japan, Taiwan, also Korea, was to develop what we called a pathway by which our colleagues, our clinical colleagues who are not part of this meeting, but our clinical colleagues who could actually look at this information and use this as a pathway to improving outcome among their surgical patient populations. So there is great concern among many of our colleagues over some of the issues you've just brought up, but it's an educational component. Again, people have a concept that I'm going to err on the side of caution and give this gentleman or this woman an extra 10 days of an antibiotic. That does more harm than good.
It does, yes, yes. Well, Dr. Edmiston, Chuck.
Well, before you leave, let me tell you something that I've been thinking over the past couple of years. And after 44 years of doing this, I've kind of come to this conclusion. Surgical site infection prevention is not a solo recital. You know what a solo recital is?
Yes, sure.
It's more of an orchestra. It's more of an orchestra. And those of us in healthcare who work with our patients are part of that orchestra. So what I often tell my colleagues when I bring up this analogy, I'll say, okay, when you go into the operating room tomorrow, let's go in there and make some beautiful music.
You know, that is such a great metaphor, because it is a symphony, but you can always identify a bad instrument. So, again, thank you so much for lending your career, your insights, and your continuing great work, Chuck, to Global Health Talks. Rest assured, these comments will be heard, and hopefully people will take to heart exactly what you've said clinically, philosophically, and it's been a delight having this chat. Thank you.
Well, Michael, thank you for the opportunity.